Welcome to the Benefit Period Effects on Claims webinar. I am Tom Ryan with Provider Outreach and Education. Today I'm joined by Mary from my team, and she's one of my friends. She's going to be helping me out, monitoring the chat, answering your questions, and getting us through all the issues that may happen. There are other members of my team that may be on, so you may hear them throughout the morning, or as a question comes up, they may jump in and answer, but just so you're aware that they are available if I need them. Little housekeeping stuff. First, the presentation, the PowerPoint, is available on our website in the Training Center. In the Training Center, you can go to the Live Events page. This will then give you the opportunity to download this presentation so that you have it available. It is not a requirement. It is not a requirement. Presentations are typically available for about 5 days before the event, so you want to make sure you're aware of that. We do load a lot of them either on Thursdays or Fridays of the week before the event. Once this event occurs, then we will move it and we will record it and make an encore presentation, which will then be posted to our website. Along with that encore presentation, should you open it and look at the player on the bottom, you'll be able to download what is called follow-up materials. That is the presentation again. So if you don't get the presentation today or you're busy focusing on what I'm talking about, you still have the opportunity to get it. You will have to wait a few days, typically a week or two before we get it posted, but it will be available to you. A little bit about this webinar. I will take questions in the chat. I've built in multiple times to stop and review those questions and to go through the information. So hopefully you can add those questions as we go. I did get pre-submitted questions, okay? The pre-submitted questions will be answered as best I can based on the information given. We're going to talk more about that. Also, we do have a survey that comes later in the event, and we're going to ask that you take that survey. The survey is really important to both us and to CMS. I'll explain more about this survey in just a little while. So for anyone who's been in Medicare for more than a couple of minutes, you know that Medicare has changes that occur, and sometimes frequently, other times it's a longer period of time between changes. Really just depends on what you're looking at. We wanted to assure you that the information within this presentation was current and accurate. I verified as much of the information as I could this morning. It's good to go. It's as current as we can get. However, if there's more current information, it will always be available on the CMS website, cms.gov. That is the official website for the providers and the MACs, the Medicare Administrative Contractors, which is what WPS is. So that's our official website. We do offer a website. It's wpsgha.com. That website offers contractor guidance. So official communications is on the CMS website. Contractor guidance from your MAC is on our website. Hopefully you are aware of that. To make you aware, the questions that I'm going to answer, there may be a few of them that I ask you to put additional information, or the answers that are given are going to be based on the information accurate today. So again, they can change as well. So if you are always wanting to keep track of what's going on currently, what's happening, please know that even though it may be static for a number of years, a benefit or something can change also within Medicare. What are we looking at? Today, we do want to talk about the benefit period. Now, this is the Medicare benefit period. We will focus on how it affects claims. We're going to define it. We're going to talk about the effects on both Part A claims and Part B claims. So we'll talk about inpatient claims, Part A claims, Part B claims, which could be outpatient, professional services, and supplier claims. We'll talk about all of this together. Keep in mind, this is not a billing course. We aren't going to focus on the bill itself and how you get that bill into us. What we do want to focus on is what causes the overlaps, the overpayments, and the denials of certain services during those time frames. Which again is why we're going to define the benefit period. Then we're going to talk about how it affects the claims, but not specifically billing. And then we're going to talk about starting and stopping of a benefit period and why that's important to understand. So as I said, the first thing we really do need to do is define a benefit period, because by defining it, we can then talk about how it's used and hopefully provide that general understanding. I will tell you, we received 3 questions that asked to start at the beginning, start with the basics. One of them said, I'm new, I don't even understand what a benefit period is. So let's do that. Let's start to get those people up to speed before we move any further into all of this other information. So let me define for you what a benefit period is. A benefit period is Medicare's way of measuring the use of medically necessary hospital and skilled nursing facility inpatient benefits. Did you catch medically necessary, the word hospital and skilled nursing facility, and inpatient? Those three key items make up the basics of the benefit period. So medically necessary, hospital and skilled nursing facilities, and inpatient. This is a Medicare Part A coverage. Medicare Part A means that the facility is being reimbursed. Okay, that's a benefit day under Part A, and we're going to talk more about that, but I want you to at least have heard it when we get to it. A benefit period is not used to measure outpatient services performed in these types of facilities. Not used for that. However, it cannot restart at times because of certain things, and we're going to talk more about that. So Medicare uses the benefit period to determine the number of payable inpatient days based on the facility type. One of the questions we got is, what is incorporated in a hospital? And we're going to talk a little bit more about that, but I want to remind you that a hospital is not just an acute care hospital. There are a lot more types of hospitals than that. For instance, a critical access hospital, inpatient psychiatric facility, inpatient rehab facility, all meet or fall under the definition of a hospital for this purpose. So hopefully that does answer that question. So when we use a benefit period, what it does is determines the inpatient Part A deductible that applies and the copay days. It also determines whether it is a full pay day or if there just isn't any more to pay. All of that equals the benefit period. Let's go ahead and talk a little bit about use and get through that basic definition and how that all works together. So first, what is it used for? I love the comment that someone gave me that said it was used to annoy you. Nope, really not the goal, but it might do that. Okay, so that's kind of a cute little piece of humor I thought that someone did a really good job with. The basic use of it is to determine whether or not inpatient bundling applies. In a hospital, it's called inpatient hospital bundling, For a skilled nursing facility, it's called skilled nursing facility consolidated billing. It's a form of bundling. It makes the inpatient facility responsible for all services that they could perform. With skilled nursing facility consolidated billing, there are things that just are not within the scope of a SNF. A SNF would never be able to do that. And that's a little bit more of things that would not be bundled. It also is used to determine a patient liability. If you don't understand that, there are deductibles that can be applied, co-pays that can be applied, and full pay days that Medicare can assign for each type of benefit. Based on that, that is the patient liability, which then determines how much Medicare is going to pay for something. So for instance, when you talk about bundling and you're talking about an acute care hospital, everything bundles into the inpatient prospective payment system, which creates a per diem based on a diagnosis code versus a service by service payment. That per diem then takes into account whether or not the A deductible has been met for that benefit period and whether or not the patient has other things that apply, such as coinsurance or copay, the flat amount they pay per day. So hopefully that helps you understand a little bit about what it is and then how it's defined or how it's used, okay? Let's move on from there. One of the questions that we got about benefit period is observation care. Is observation care inpatient care? It is not the same thing. You can have an inpatient order, which is one form of care, or you can have an observation care order, which is a different form of care. Observation care is considered a Part B outpatient benefit. They are not inpatient in a facility. Therefore, the benefit period does not apply to that time frame, nor do the inpatient bundling. Note the inpatient bundling rules. So keep that in mind when you're looking for these types of things. We'll talk more about that if you have questions about that. The basic, we're going to run through some basic questions because we did give you the basic definition. Hopefully I got enough information for y'all to have what you needed for those of you that were new. If not, though, I would really recommend or encourage you to use that chat feature. Before I ask Mary if we have any questions, I do have 2 pre-submitted questions that I just want to reiterate. What does a benefit period include? So this answer is designed for the following. It's going to include benefit days and non-benefit days. I will explain that in a little while. But a benefit period is inpatient Part A benefit days, which means Medicare Part A is paying, and inpatient Part B benefit days, or in other words, the facility portion is done. We're outside of the number of days that will pay for the Part A stay, the room, the board, the nursing care, all of that. However, they're still in a medically necessary stay, so you could bill Medicare for anything that would be covered under the Part B portion or the Part B benefit program. A benefits period will incorporate the Part A deductible days, the Part A full pay days, the Part A copay days, and again, those benefit exhaust days. That's why we have a Part A and a Part B inpatient stay. In other words, if the patient remains in a medically necessary stay, the benefit period continues. And we'll talk more about what breaks that up or what makes that lapse in a little while. They've heard the term benefit day and benefit period. Their impression is that a benefit day is the same as a benefit period. And as I just explained, this is not true. A benefit day references a day in which Medicare is allowing for the facility service. A benefit period incorporates both benefit and non-benefit days. This does directly affect billing, because if they're in an inpatient stay and it's a Part A stay, a benefit day, you may have to bill the facility for certain things, and you definitely do have to bill them for some things, but those things may be billable to Medicare should they be in a benefits exhaust or a Part B portion of the benefit period. So we'll get more into that next. Those were the 2 questions that we did have, and I wanted to make sure I addressed them. Mary, did we have any other questions just on the basic information?
Tom, there are no questions.
Okay, let's go ahead and move on. Claims is next. And this is really what brought this on. So what we do is we do data analysis and we look at it. For our purposes, we call these overlapping claims. They are claims that are billed to Medicare that overlap an inpatient stay. And during that inpatient stay, the benefit period is what is used to determine whether it is a Part A stay or a Part B stay. So that's why this information is being put together. It is a high denial within Medicare when you put all the forms of it together. I did want to spend a little bit more time on bundling, just a bit more time, because there's a little confusion on it. So I will show you a couple of websites, one in particular for the skilled nursing facility. And I think that may help clear up some of that confusion that was asked of me other questions. So first, whose responsibility is it to determine who to bill? This is a question that Medicare has answered. And what they have said is that it is the provider's responsibility. This means that you should use things like eligibility, the patient themselves, and other facilities to determine who to bill before just simply billing Medicare. If you simply bill Medicare and you continue to do that, at first it will be Medicare abuse. If you're educated on it and where you're asked to stop doing it, it can become fraud and can become an investigatable offense. It does cost the Medicare Trust Fund money to process those claims to tell you you need to bill someone else. That's money that we're trying to avoid costing. So who do you have to determine? We'll start with the hospital. Are they in an inpatient hospital of any kind? Now, please remember that hospital is not defined as just an acute care hospital, and we will talk a little bit more about that. Are they in a skilled nursing facility or a SNF? This is different than a nursing home where they live. They may not even be getting skilled care in that nursing home at all. It might just be where they live. Not the same also as a older community, whether it's 55 and older, 65 and older, or whatever, or assisted living. These are different. Skilled nursing facilities have very specific criteria. Sometimes you have to determine whether the patient needs to be billed for that. This was one that I was asked specifically about, so let's just stop right here for a second. You will bill the patient for anything that Medicare never covers. It is not part of the benefit program. So even if they're in an inpatient hospital stay and you give them something for a comfort item or you supply them with something that is never covered by Medicare, that will still be the patient's responsibility. Or do you bill Medicare? Now, again, this is when they're inpatient, it's medically necessary, but the inpatient days have lapsed or are done. It's a little bit different there. Along with the bundling concept, there's also another concept that falls into overlapping claims, and it's called a split billing concept. The split billing concept is used for certain types of services that have a professional and technical component. Because the technical component during an inpatient Part A stay is billed to the facility, they must pay for it or coordinate the care for it. So it's part of theirs. Now, the professional component is not. The professional component falls under Medicare Part B and is not considered a facility expense. It is a professional expense, similar to like a nursing visit in a skilled nursing facility where the doctor is going to bill that nursing visit directly to Medicare. It's a professional expense, not the facility expense. So hopefully that does make sense. So when we look at this, we also then have to look at what is called a 3-day or a 1-day payment window. 3-day or 1-day payment window. This is for those services that are diagnostic in nature and have certain components. And what happens is 3 days preceding the beneficiary's admission into an acute care hospital or into most care hospital, those services become bundled into the inpatient care. This applies to all diagnostic and related non-diagnostic services. So all of a sudden you're like, wait, I billed it, I did it correctly. And Medicare comes back and says, wait, this diagnostic service is part of this inpatient stay. And you're like, but it was done 2 days before that. It was literally 48 hours before that. It doesn't matter. That's part of the bundling rule that applies. So the 3-day and 1-day payment window respectively is codified in the Code of Federal Regulation. In other words, that's where it's going to explain it. And you want to look at 42 CFR 412.2C5. Then for hospitals, you're looking at subsection D. For non-subsection or for non-hospitals, you're going to continue to look, but you're going to look at 413.40C2. I'll put all this into the chat. I don't expect you all to be able to remember all of this. And then also there's some information in the Medicare Claims Processing Manual that will help you get through this. So if you're interested in that portion of split billing, which is again part of the information you may need, please take a look at these different sections. It is about the 3-day and 1-day payment window. We did have a few questions which were very, very general in nature regarding it. So I tried to work the information and keep it high level when I explained it. So hopefully I did what you guys needed. All right, one of the other questions we got, is about patient liability. And so what is considered patient liability? Well, remember that the liability is what Medicare assigns the patients. It's really that simple. So when we talk about liability, it is based on the amount given per day or per stay. Okay, given per day or per stay. In a professional service or an outpatient setting, you're going to hear the Part B deductible and coinsurance apply. Remember, a Part B deductible is an annual deductible, and applies after the Part A stay is complete. So if they stay in the hospital and they enter, there's no more benefit days left, then we would apply this. We're going to talk more about the benefit days coming up. I know I've referenced it a few different times. I just want to get through the basics of some of these other things first. A co-insurance day is a 20%. Services on a Part B basis, for the most part, have a 20% co-insurance. Probably the most notable exception is preventive care, if it meets a level 1 or a level 2 assigned by the United States Preventive Services Task Force, then they wouldn't have that. Inpatient liability is different based on the facility type. And that's what we're going to go through next, because inpatient liability is completely different. But that definitely affects your benefit days. Okay. So the first thing we have to do is start with hospitals. But before we get too far into hospitals, we have to define what it is. What is a hospital? Most of you say, yeah, hospital is a critical access hospital. Yep, that would be correct. Or it is an acute care hospital. That's what you know. It's got different trauma levels, all of that. Yes, those are types of hospitals. However, an inpatient psychiatric facility, inpatient rehabilitation facility, long-term care hospitals are all considered hospitals. Hospice is not a hospital, but can be performed in a hospital. It's a benefit that is that is individually elected, not privately elected. The patient elects hospice. Hospice can be done in a variety of different settings. It is not necessarily a facility type, but it can be. Can you go to a hospice facility? Yes, but it does not apply. Hospice has its own set of rules. It is not part of a benefit period. They use election periods, which are completely different than benefit periods. So that's why hospitals does not include hospice. It's a separate part of the law. It is a separate benefit under the law. Okay. So when we look at hospital benefit periods, what are some key understandings? First, with a hospital, Medicare covers 90 medically necessary days. This is the inpatient Part A benefit. It applies deductible for the first 60 days, and the remainder of that is covered at a 100%. And then they have copay days for 61 to 90. Don't read on, stop there. When we stop there, once they were to reach that, everything after that is the patient's responsibility. That's where the Part B benefit portion comes in, okay? So benefit period, benefit days. Benefit days for a hospital start with 90. Again, deductible and copays. Now you say, why didn't I list directly what the deductible is and what the copay is on this slide? The reason I don't do that is they do change annually. So if you're referencing this material down the road, it's better for you to go to the CMS website and actually look it up. It's the best way to do it. You can also Google 2025 Medicare hospital deductible. It'll bring it out for you. I don't want you to think that it doesn't change and it becomes static. So that's why I don't list it directly. Okay, now when we're talking about a hospital, there's also some additional days that are optional. And I want you to highlight, circle, draw a line around, do whatever you want, because I want you to remember that the optional days are the patient's choice to use days. They are considered benefit days, but a patient may only use them once in a lifetime, unlike the other 90 days, which will renew each benefit period. Once in a lifetime versus renewal each benefit period. Okay? These are called lifetime reserve days, and there are 60 of them. No, a patient does not need to use all 60 at once. If they use 15, 15, 30, so it's 4 separate uses, that is okay. Okay, they're lifetime reserve days. Things to note about the lifetime reserve days. They do not have a separate deductible, but they do have a higher copay. It's almost double the copay of the first set of days, the 61 through 90. So some people will elect not to use it. It is their right to do that. If they choose to use them, though, it does count as a benefit period continuation and a benefit day. So then once you hit day 91, if you don't use the lifetime reserve days, or 151 if you do. Again, the patient becomes responsible for all expenses, and that's when we move to the Part B stay, which says bill Medicare for anything Part B would cover or outpatient care would cover. So that's a hospital benefit period. Similar to a hospital benefit period is a skilled nursing facility, medically necessary stay, and I'm sorry, not benefit period. Those are hospital benefit days. A skilled nursing facility also has benefit days, and it does begin with medically necessary stays. It also has some qualifying stuff that we'll talk about in just a second here. So if the patient remains in a skilled nursing facility and it's medically necessary, they will continue a benefit period. However, they will only receive 100 benefit days. That's it. That's what you got. Okay. We'll split that out in just a little bit more. When we say medically necessary stays, can they stay in the skilled nursing facility and always have a covered stay? And the answer is no, because they also have to have a medically necessary inpatient hospital day of at least 3 consecutive Medicare days before the skilled nursing facility requirement begins. Did you guys catch the 3 consecutive days? That does not count the day of discharge. So it will count the day of admission, second full day, third is a full day, the last day is your day of discharge. That does not count. Some people like to refer to it as 3 midnight census counts. That's fine too. That's what we're looking for. If you do not have that, Medicare will not pay for your skilled nursing facility, even if it's medically necessary. A benefit period is not used during that time. One of the other questions was, is there a time limit that they have to enter into the SNF in order to continue the benefit period or for the benefit period to continue? The answer is yes. They have to go to the SNF within 30 days of their 3 consecutive days. Hopefully that all makes sense. So yes, a SNF stay has to be medically necessary, but on top of that, there's a bit more that goes into it, okay? And you will see on this slide, the 60-day count begins, but does not automatically end the benefit period. So they stay in the skilled nursing facility. They're there, but they're not in a medically necessary stay anymore. That'll count the 60 days towards ending the benefit period. It has to be a 60-day lapse. We will talk more about that in starting and stopping, so don't get super confused about that. I was asked to elaborate a bit more on skilled nursing facilities. So I'm hoping this will meet what you needed me to elaborate on. If not, please let me know. But keys to understanding a skilled nursing facility benefit period and benefit stay. First, what applies is a SNF and swing bed stay. Swing bed is a hospital bed used to meet the skilled nursing facility, not meeting the full inpatient criteria, instead meeting the continuation care that comes with skilled nursing facilities. The skilled nursing facility or swing bed benefit is 100 inpatient days. So remember we said during a hospital you get 90 with the additional 60 once in a lifetime, but during a skilled nursing facility it's 100 days. Now again, you do have to meet the 3-day qualifying stay and the admission timeframes. During that first 100 days, 20 days are covered upfront at 0 expense to the patient. 0 expense. There's no deductible. Deductibles are already applied for this benefit period during the hospital stay, right? That's where it starts. So then also there are 80 days in which the patient has a copay or a percentage, or I'm sorry, a flat amount share. That again does change annually, so you'll want to look that up and make sure you're checking it and seeing what's there. Okay. So on day 101, or if it is a not medically necessary stay, the patient is liable for all expenses. Oops, sorry, I didn't mean to hit the advancement there. So there's a lot of things going on with these different things that you'll need to be aware of, okay? Hopefully we can get through more questions if you have them. Sorry about that. Just had a little cough there. So again, I want to remind everyone, we did have some pre-submitted questions. The questions were about hospice. So let's explain a little bit about hospice. Hospice does not fall into the hospital benefit, nor does it fall into the skilled nursing facility benefit. Therefore, a benefit period does not apply. Hospice benefit, on the other hand, does use the days. That's normal, but it's not a benefit period day. It's not a benefit day. Hospice has its own set of days, and that's an election period day, and it's designed to say, hey, they're going to have so much time. You can have as many elections periods as you want, but it's not a benefit period. It does not mean that hospice does not have its own bundling rules. It does, but they are different than the inpatient, skilled nursing facility, or hospital bundling rules. They do not apply the same way. And because of that, I could teach you a whole hour long on just on the hospice information because it is so different. So I do not want to get into all of those different things. I do want to move forward and show you a couple of things that we were asked about, and then we'll go ahead and jump into the questions in the chat. So the first thing I'm going to do is just bring up the website in general, and I'm going to go to the CMS website, and this is cms.gov. What I was asked about is when we try to locate the benefit days or the deductibles, all of that, can we find it really easy? I would actually say yes, you can. This is how I do it. I don't try to like navigate to any of this stuff or any of that. It's too much work for me. So go ahead and search it. There's going to usually be except you got to make sure you spell it correctly. There's usually going to be like a news release on this as well. So okay, here it is, 2025. Awesome. Nope. There we go. It'll just walk you through it. You can see the Part B, the Part A. If we get down a little bit further, it'll talk about some of the adjusted incomes. I'm just getting down to it. So it'll talk about your Medicare premiums and your Medicare deductibles. Okay, I was asked a question about what happens if someone discontinues paying their Medicare Part A premium. Then the benefit period does not apply because they no longer have Part A coverage. I don't want to confuse people. Most people do have premium-free Medicare Part A. It's premium-free. They don't have to pay for it. On the other hand, if you have not worked 40 quarters in a lifetime, so 39 or under quarters in a lifetime, then you can pay for it. It's just a different set of money. So hopefully that makes sense. If you're looking at the deductibles, it does talk about here's your deductible, here's your days, here's your lifetime reserve days. And if you notice, I said, remember, it's almost double. It literally is double. It's 419 or 18 or 838. So lifetime reserve days, that the copay amount is double that of a non-lifetime reserve day. This is why some people elect not to use it. They just don't find it worthwhile during that stay. And then here's your skilled nursing facilities, 21 through 100, and it's $209.50 this year a day. So if you're looking for that information, I'm always going to recommend just go to the CMS website, look it up that way, or Google it, use a search engine, whatever search engine you so choose. I do think it's easier than like myself sticking it in there for you. Okay. I was also asked a couple of questions about skilled nursing facility in general. We'll get more into that, but you can always do on this website, underneath here, go payments, look at the different fee schedules and the different ways we pay. Skilled nursing facility uses a prospective payment system. So if we go into the prospective payment systems, we can read through all the different files, and you can see down here on the bottom, this is going to be the prospective payment system. We do teach classes that talk about all of these different items that go with that. So I just want to remind everybody of that. With that said, that's kind of going to bring me to the last question that I had pre-submitted. I know I generalize those questions a lot, but I will give you the opportunity to put them back in chat should you need more information. With that, Mary, do we have anything in chat?
No questions in chat.
Thank you. Okay, let's move on then, and let's talk about starting and stopping a benefit period. So remember, a benefit period does incorporate benefit days, but not always does it stop just because there are no benefit days left. We talked about that. It continues. So a benefit period is much broader than a benefit day. So what starts it? Well, an inpatient admission starts it. That it's as simple as that. Was there an inpatient admission and was it medically necessary? If there was, that's what starts it. Someone did ask me a question about when an inpatient admission would not be medically necessary. Well, medically necessary is a very vague term. I'm going to say that very, interestingly there. So one of the things that makes it medically necessary is the patient's condition. But there's also payment criteria. It's not about medical necessity. And that's an order. So that is, I think, where the question was coming from. Because remember, the order is for observation. It's not an inpatient. It doesn't start a benefit period. If the order is for inpatient, they are admitted inpatient. We do the evaluations, all of the different things, then it will start the inpatient in a hospital. Also, if for some reason a skilled nursing facility before the admission to skilled nursing facility does not have a 3-day qualifying stay, and that 3-day qualifying stay wasn't within 30 days or planned to be outside 30 days, which that's a whole separate set of rules, then that would also not meet the technical criteria. So it could be medically necessary. We're not saying that. We're saying it doesn't meet the Medicare payment medical necessity starting points. So a benefit period begins when an inpatient admission is medically necessary and meets all of the Medicare payment criteria. It continues so long as they remain in a medically necessary stay. This would incorporate any Part A deductible days, any Medicare full pay days, any Medicare copay days, and any benefit exhaust days. On this one, remember to note that a benefit exhaust day is when they are inpatient, it is medically necessary. They remain at that level of care. However, they are outside either the 100 skilled nursing facility days, because that's all you get, the 90 hospital days, or the 150 hospital days if they've elected that lifetime reserve. That's what we're looking for when we talk about a benefit exhaust day. The Part A benefit is exhausted. No more paying. Okay, so we know what starts it. We know what's included. So then what stops it? What stops a benefit period is 60 consecutive calendar days with inpatient care lapse. In other words, there is no inpatient care for 60 consecutive calendar days. This is not based on a certain facility type. So just because you go back to a hospital from a skilled nursing facility and you haven't been in a hospital for over 60 days, but you were in a skilled nursing facility 39 days ago, it doesn't matter. It's also not based in a patient's condition. So that means that just because you're looking at it and saying, hey, they fell, they broke their hip after leaving the hospital because they were sick. So they were out, they got sick, they stayed in, now they fell and broke their hip, but they were only out for 40 days. That will not stop a benefit period and restart because it's a new condition. That's not how the rules and the laws are written. It has to be 60 consecutive days with 0 inpatient days. So I wanted to make that about as clear as I can get it, so that you're kind of getting the difference there. So remember, it starts with a medically necessary inpatient stay that meets the Medicare coverage criteria. It then continues through all of the deductible, all of the full pay and copay days, which are your benefit days, moves into your non-benefit days or your benefit exhaust days, and continues until we have a 60-day stop. So let's keep going on with this a little bit more. So benefit days, again, we've already talked about this, but I kept putting it back in there because there seemed to be some confusion. So let's move on. And just, again, put this slide back in there. Use this slide if you need to. Use it as a reference. Give it to someone. Help them out. It's all medically necessary inpatient days, regardless of what Medicare is paying. That is a benefit period, but a benefit day only counts that Part A stay. This is a benefit day. Again, remember, limited coverage services means that it has to be covered under Medicare Part B for it to be part of the Part B stay. Let's talk a little bit about things that don't count as a benefit day. So even though they're in a medically necessary stay, if they're on a leave of absence, so you were to bill that as a facility and you say, hey, you know what, they're still inpatient here, except this day at midnight they weren't here. Sometimes this happens if they need to go to an emergency room. Not that you discharge them or anything like that. It's just at that midnight they weren't there. They left at 10:30 at night and they got back at 2 a.m. So for that midnight they weren't there. Observation care does not count. This is an outpatient benefit, as I mentioned before. And so what happens with observation care sometimes is that an inpatient day is overturned and it's like, no, this should not have ever been an inpatient stay. That's a separate form of bill. And it's very specifically talked about in CMS's guidelines. And we're not going to get all into that when we talk about this because it doesn't really affect the benefit period in that manner. We just know that it doesn't count towards the benefit period. Also, outpatient care doesn't count. The example given here and the question was asked if continuing outpatient PT, OT, and SLP services in an outpatient setting would continue a benefit period. I'm going to assume it's something like an outpatient hospital setting. The slide example says outpatient surgery center, could be part of a hospital. It's outpatient, so therefore it doesn't count. As soon as you say the word outpatient, you begin calculating the end of the benefit period and do we have a 60-day lapse so a new one can start. So let's move on. A couple of examples. I was given some different examples and I built a couple in myself just to kind of help everyone. So first, John admitted to the hospital through the emergency department after a suicide attempt. He remains in the acute care hospital for 10 days for medically necessary treatment. After that 10 days, he is then transferred to an inpatient psychiatric facility for 30 days and discharges home on day 31. Okay. Admits to a hospital 49 days later. So we need to circle 49 days. That becomes important. He remains in that acute care hospital for 23 days and discharges to home health on day 24. So home versus home health. Key things to keep in mind. Is it one or is it two benefit periods? In this case, it's one. Why is it one? Well, if we look at it, we find out that he was only discharged for 49 days. That's inpatient psychiatric facility to acute care hospital, right? 49 days. That's one continual benefit period. Why is that important? Remember we talked about the deductible period and how many days applies to deductible? So when we look at this one, he has 60 days, but he only has 3 copay days. Why? Well, when you add it all up together, he started with 40 days in the first 2 stays. Well, then we got to go to 60, which means that he goes 20 remaining days out of that. That's all your deductible days. Once that deductible is met, that left him with 3 copay days. So that's an example that was given to me. Hopefully that makes sense to you and how to calculate that benefit period. Let's move on to the next one. So this one, oh, I'm sorry, this is the calculation. I just went through it, so I apologize for not advancing that slide. Judy resides in a nursing home. She has a hip replacement. So she resides in a nursing home becomes key here. It's not medically necessary. She's not under skilled nursing care. She just lives there. She remains in the hospital for 12 days following the procedure due to an infection. Okay, so 12 days, we're good. After hospital discharge, she returns to the nursing facility where she lives for medically necessary skilled care. So though she lives there, she's in a different bed receiving medically necessary skilled care. She is discharged from the skilled care after 63 days and remains at the nursing home as a resident. So back to not medically necessary. After 63 days, she is admitted to the hospital for a left hip replacement. Okay, so she had one, now she's getting the other one done. What do we know about this one? Is there a 60-day lapse in medically necessary care? And the answer is yes, there was in this case. Remember, she had that time where she was home. Home being, yes, a nursing facility, but not in skilled care. Even though it was the same physical building, she had 63 days between the two. That means that the second time she enters into the hospital, she will start with the deductible over again. So she moved to that non-scaled level. She remains in the same facility, but she does have a 60-day lapse in care. Yes, this will start a new benefit period. New deductible begins applying along with copay, all of those types of days. Example 3, April 12th, Jake has a car accident. He admits to observation following an ER visit. Observation. April 14th, a hospital admission occurs due to a complication. So we know that for the first 2 days, not going to count. May 23rd, hospital discharges to SNF admissions occur. On July 17th, the SNF discharges to home health care. Home health care is key here. On September 8th, the hospital admission for a medically necessary surgical procedure due to the car accident occurs, and he then discharges home on September 15th. Does this begin a new benefit period, or do the benefit days continue? Here is the benefit days. 1 benefit period. Why? On day 1, April 14th, hospital deductible and copay begin to apply. Day 25, discharge from the hospital to the SNF. So now SNF days begin to apply. He's then given day 60, discharge to home health. Day 61, adjust August 8th, admission for a surgery. And day 67, discharge home. On July 17th to September 8th is not 60 days. That lapse of time did not occur. Therefore, because it's not 60 days, it's 1 continual benefit period. That means that the days laid out above are the days within the benefit period, not necessarily the benefit days. Now, it could be the benefit days and they could continue. We just don't know if Part A expired or whatever happened within that time frame. We didn't talk about all of that. So hopefully that makes sense to you for that calculation. All right, a couple people did ask to give some resources and we thought these were important. So the Medicare Benefit Policy Manual, Chapter 3, Duration of Covered Inpatient Services, and Inpatient Hospital Billing, which is the Medicare Claims Processing Manual. These are your basics for what I gave you and a lot of the information that you're going to need. So it's important that you're able to find those basics. If you want to open one of them up, just select the link on the slide and it will open it up. Obviously, it's verifying something, and then it'll pop it open for you. Great information. You can walk through all of this. Benefit period, spelling of illness, and it talks about all the things we just talked about, okay? All right. Same thing would happen if you open the other one up. Let's move on. Let's do a little wrap up here. First, I'll start with some pre-submitted questions, get through the rest of those, and then we will move on to any questions that you have. So first, if we have the provider and they know the beneficiary should not have a new benefit period because they use days at another provider, but no payer informational claims have not yet been processed, how do we justify not utilizing the benefit period as shown? So keep in mind that, it's the benefit days as shown. Keep in mind, you'll want to bill these and you want to make sure you get these in, and it will calculate the days out. The benefit days will be used on a first come, first served basis in terms of coming in. They're not necessarily billed in sequential order when another provider is in. Now, if it's your claim and you used them all in your facility, of course they have to be sequentially because your claims have to be sequentially. So how do you justify not doing that? I don't know that you necessarily do, but you do want to document this information. You may want to contact the other facility if you know it to find out what's going on. Sometimes they have claims that are held up. Sometimes they have claims that are not processed. All of that different things can happen. So depending on what's going on with their claims within the system, this can definitely affect your claim. How do you verify claim status real time is the next question. And the best place to actually do that is on our portal. Remember, the information is dependent upon billing though. So when you're on our website or our portal, if you go to WPSGHA.com, this is the portal. It is a login section. There is an area called eligibility. So if you come down, you read your introductions, creating accounts, all that kind of stuff. If you come down, you can do an eligibility check. Now, I can't actually go in here and look anything up because I don't have access to the PHI and PII, but what I can show you is just a screen print. It'll walk you through it and make sure you're in eligibility. Again, look away, check your summary. Your summary will begin to give you some basic information. What are your entitlement dates, all of those types of things. your overall benefit days if you need that, but then you can move to the deductible, which would be the next screen. And here you'll find different things about deductible, days remaining, hospital, all of those types of things you might need. So hopefully that will help you. The reason that I added the caveat is this is only as good as the processing system. If we have not had claims submitted from a provider, we may not have this information yet. So for those of you that are not aware, hospitals don't submit necessarily every so many days. They do go admit to discharge at times. And if it's an over, let's say 30 days, they may submit an interim bill, except the problem is if one of their interim bills gets stuck, they can't submit the following interim bill. And then they can't submit the following one. Should that still be stuck? So everything has to be submitted in a certain manner. And that's why some of this information isn't always up to date. This is the portal user manual. Again, it is available on our website. That website is wpsgha.com. It's always going to be in this upper corner. Select portal user manual, and then you can scroll through until you find what you need. Okay. That is the best way to verify real-time status. Now, I will tell you, if you do have direct data entry or DDE, the information is in DDE as well. That is not for all providers, though. Only certain providers billing on a UB04 or 837I with access to the physical intermediary standard system, or FIS, can have access to that. And you do have to pay a vendor to get access to it. So just keep that in mind. Next question. When do benefit periods start if a patient was admitted during a new year? So the way that it's written is that there is no year consideration. A benefit period must have a 60-day lapse. So therefore, the new year does not start one. An example of that is a patient may have one benefit period when the benefit never lapses for a lifetime. Our example, and the best one that we have for this, was asked about tube feeders. So they're getting their caloric intake and they're getting their fluids, and it's considered skilled stay, and they're in a nursing home. Guess what? That will never start. Never start. Okay. So just so everyone is aware, there can be one benefit period with benefit and non-benefit days for an entire lifetime under the Part A benefit category. How do you help the patient understand their benefits better? Do the best you can. You can always take them out to this website, which is medicare.gov. It is the patient's website. Their basic benefits are laid out in a guidebook called Medicare and You. This handbook is something that is mailed to them and may help them understand, but ultimately, if they're not getting it, you do need to refer them to 1-800-MEDICARE. Somebody asked about a specific tab on the WPS portal, and I can't get into it, so no, I can't do that. If you want to take a look at the classes that we actually have on our portal, you may find the information you need there. They have screen prints and other things that they use that I did not prepare for this because we were not going specifically into the portal. Again, here's another question. We bill outpatient dialysis treatments on a UB04 for Part A. We receive a B9 patient in hospice, but we are unable to contact the hospice agency during the contact information. Okay, let's stop right there. This is not a benefit period denial. This is a hospice denial. Once again, the hospice benefits are completely separate. We do not process those. We are not part of that. Here's what we know. If your claim contains a hospice diagnosis, we will reject the claim based on the hospice benefit. The claim must then be sent to the hospice and it must be processed through them. That's a different form of bundling. It is not a benefit period consideration. That is my last question. So Mary, do we have anything in the chat?
There are no questions.
Okay, let's move on. Want to remind everybody that you're going to get an email in just a little while. The email will contain a certificate of achievement. It's going to give you the contact hours for today's event. The contact hours can then be translated into CEUs by a governing body, but we do not directly issue CEUs. The contact hours and the certificate of achievement will look like the bottom portion, the bottom red box on your slide. The top one talks about the survey, and I'm going to talk about that in just a few moments, but it's just another opportunity to take the survey. If you do have follow-up questions related to today's content, not specific to a claims questions we can't answer, go ahead and email those into us. We'd be willing to take them for the next 7 days, and we'll get through the information back to you. So keep that in mind. We will take those for 7 days. Next, the survey, which I keep saying I'm going to talk about and talk about. The survey is very important to both WPS and CMS. This feedback that you provide helps us understand, are our webinars effective? Are we doing what we need to do? What education can we do that will better serve you? What topics are we missing? What topics do you want to see? Are there topics related or unrelated to what we talked about? All of those types of things are key to understanding this. So with that, I'm going to have Mary put a link in the chat that you can take the survey right now. I gave you an opportunity to see where another link will be. Remember, that was in that follow-up. But another opportunity will be given when we close out of this webinar, and it's called the external site. It's in the bottom middle of your screen, and that's what it's going to look like. Last, I want the survey so much that if you take it as an encore presentation, you'll be asked again to take the survey by using the picture in the upper side. And you can see it says online survey. What we're really looking for is to get that feedback any way we can and to get whatever feedback you have for us, the good, the bad, and the ugly, I like to say. What did I do well? What do I need to improve on? Did you like my presentation and resources that I showed you? Were there things that would have been more helpful? So give me the good, the bad, and the ugly. That's my pitch on the survey. Please take our survey. All right. Thank you for attending. We do appreciate your time today. Remember to download that presentation, either grab it now or before tomorrow morning. Otherwise, you do have to wait a few days until it's put up back into the Encore. Please remember to give us feedback on the education today, but also on any future education you're looking for. It doesn't have to be related to today's topic. Remember to check our live events page. We do offer a variety of different courses, and they do range from billing to medical necessity to benefits and coverage. So there's a lot of different things out there. On behalf of myself, Mary, all of Provider Outreach Education, and WPS, thanks for participating. We're glad that you spent some time with us today. We look forward to your survey comments, and we hope that you'll join us again in the future. You may now disconnect. Have a great day, everyone.